clinical perspective of what's going on here. The first case is a man with 52-year-old man who was a known diabetic on treatment and came to hospital with complaints of defective vision in the left eye for the past 2 months. And and he was sudden and onset and painless. It's not 2 months, it's actually 2 days. So this is the finding. Like, he had very poor vision in the left eye, the right eye was normal, and this is what you see here. You have a combined retinal central retinal artery as well as the central retinal vein occlusion with again apparent both the vein occlusion features as well as the arterial occlusion features are apparent here. And this is the fluorescein angiograph, which shows the extensive non-perfusion. Almost total capillary network is knocked out with not much perfusion anywhere in the retina, extending till the periphery. And this already it has been discussed, and this is what happened when we investigated him. He had a plaque in the internal carotid artery with more than 50% stenosis, along with the concentric left ventricular hypertrophy. So the question is how he was treated. But again, Dr. Mahesh Annam was stressing on the higher risk of neovascular glaucoma. I just wanted to put it across to the panel whether they would wait till the first sign of neovascularization occurred in this case before going for a PRP, or would you directly do PRP at the first sitting itself. The case patient was a 15-year-old male who came for a routine checkup for his presbyopic correction glasses. He was not really aware of the loss of vision in his right eye, and he did not have any predisposing systemic history at that point of time. So this is the patient's profile. Like, he is having normal vision in the left eye, but you can see that he's got 6/12 moderate vision loss in the right eye, which is not corresponding to the amount of cataract. And this is the finding. You can see a small superior to the macula. You can see a small area of tributary retinal vein occlusion with a minimal amount of leakage, little bit of edema and some hard X-rays there. So this was a slightly borderline cholesterol levels. Otherwise, he was okay, and as far as the systemic evaluation was concerned. And this is the OCT which showed cystic edema in the fovea with around 343 micron thickness. So at this point of time, with a really good vision, which was not, almost near normal vision of 6/12, like whether what's the consensus on how to go about treating this patient, whether to go for a conventional laser or to go for a monotherapy with or a combination therapy with anti-VEGF or a steroid. So the case number 3 is again a man aged 50 years. He was a known diabetic for the past 14 years who was on treatment. He came to a hospital with complaints of defection in the left eye for the past 15 days. It was sudden and onset, painless and non-progressive. So the right eye had near normal vision, the left eye was poor with 260 and RAPD, and he had a intermediate type of CRVO with cystoid macular edema and exudative retinal detachment. This was the picture. You can see the extensive amount of hemorrhages, this moderate disc pallor, and a lot of microaneurysms you can see everywhere scattered around. So this was the picture of the OCT showing extensive macular edema with the subfoveal detachment as well. And because of the hypertrophy of the superficial layers, there's a lot of haloing beneath. So around the CMT was around 1653 microns. So at this juncture, like whether to go for anti-VEGF therapy or taking the amount of retinal edema on account, whether to go for a combo therapy with steroids or only anti-VEGF, what's the way to go in such patients? So this was one more patient who came to us with a painless progressive loss of vision in his left eye. He was a known hypertension, was on treatment already. So he came with a sort of non-ischemic type of CRV on the left eye with a very mild RAPD and significant macular edema. And he was managed conservatively. But later on he sort of lost to follow up, but when he came back he had developed a neovascular glaucoma on the left eye, but again he went on to develop non-ischemic CRO on the right eye also. So now the left eye is lost because of neovascular glaucoma, and he has developed a non-ischemic sort of CRV on the right eye now, irrespective of extensive workup. Other than he did not have any predisposing factor other than hypertension. So initially we started treating him with Avastin, and then he had every time this sort of, he is a very long history since 2003. He is having multiple injections, and all in all he has had around 17 doses of Triamcinolone and 3 doses of Avastin. and yes, now he's on anti-glaucoma drugs as well. So now what's the way to go? He's one-eyed now, and he's having recurrent edema, and every time we give injection, he improves almost to 6 partial. So that he's able to go to work. He's still working in the office. At this point of time, how to go about treating him? He's developed glaucoma also. So this will last thing can give how to go about treating him now, sir. What are the other options apart from these injections? Like what's the role of laser in the because already CV has shown that macular grid does not work in central vein occlusion. But is there any role with the in combination with the anti-VEGF or steroids, or what is the role of plain vitrectomy or vitrectomy with radial optic neurotomy in such an event? So this patient, because he was sort of fed up and he was with the multiple injections, we did a vitrectomy with ILM peeling for this patient with a little bit of grid laser as well. This is the stage almost now 1 year after surgery, is still sort of died down. It's not totally gone, but there is still some retinal edema persisting in the temporal periphery to the fovea, and his vision is sort of stabilized now at around 612 to 618, like in that area. Thank you.